first presenter for the session today is Dr. Jose Vasquez from Mexico, Obstetric and Gynecology Hospital. He is well-known head of the Climacteric Department and ex-president of the Mexican Menopause Society. Dr. Vasquez, I would like to invite you to start sharing your presentation on this very interesting topic today. Thank you.
Thank you very much, Dr. Armeni, and thank you to the European Menopause and Andropause Society for letting me to be here with you and my colleague, Dr. Paulina Villaseca. I am going to talk about two topics very important for long-term of estrogen therapy. One of them is a well-proven one, which is the effect of in the prevention and treatment of osteopenia and reducing the risk of fractures. And the other one is still experimental, but there are a lot of data, and every time it's getting more and more that it might have some good effects in the central nervous system. So I will share my presentation to begin this topic. First of all, I would like to make clear some points, and one of them is that there is the normal cognitive decline, which is those changes related to aging, the so-called brain fog, that it is very common in the perimenopausal period. And the problem is not when the patient said, do not remember where she left her keys. The problem rests when she found the keys and do not know what these devices are for. So normal cognitive decline, very common. It is due to the chaotic levels of estrogen in this time of the life. And besides, the patient has maybe some hot flashes, which could make poor quality sleep. So there are three factors that account for the cognitive decline. Other thing is the moderate cognitive decline, in which there is changes in more than one key function, like for example, learning, verbal memory, emotions, memory, short-term and long-term, executive functions, attention and consciousness, language and reasoning. And finally, we have dementia, when there is a pronounced loss of more than one mental function. In the date of 1970 and 1980, there were observational studies that pointed out that the beneficial effects of estrogen in some mental functions, and it was found a reduction in the risk of Alzheimer's diseases of about 40%. This was due, at that time it was the thinking that to the neurotropic and neuroprotective effects of estradiol in the neurons. It was also discovered in this time by Beaulieu and co-workers that the brain was capable of synthesizing estrogen from cholesterol, what we call neurosteroids, which acted in several areas of the central nervous system via genomic and receptors and non-receptors in several areas and in several functions of the central nervous system. So here's the line dividing two periods: pre-WHI, which I am talking about now, and then it was the WHI Women's Health Initiative study, when and ancillary studies like the WIMS, Women's Health Initiative Memory Study, and the WISCA, Women's Health Initiative Cognitive Aging Studies, which reported an increase in the risk of neural decline in patients older than 65 years old. Neither the estrogen plus progestin nor the estrogen alone trial showed the expected reductions in all-cause dementia. To the contrary, the dementia rate was increased in women allocated to active treatment. So it was not indicated in prevention for this kind of diseases. Here in this graph, we can see in the first studies of this topic how the persons that ever used or currently use estrogen had less relative risk of developing Alzheimer's disease, almost 35%. And interestingly enough is that in all these studies, the patients only received estrogen, no progesterone. So there were a lot of areas of impact, and for example, we have actions in the neurotransmitters. It have been also described some effects in the deposition of beta amyloid plaques, and there are some changes in the oxidative stress that the estrogen molecule functions as an antioxidant, similar to tocopherols, and also in the process of inflammation via the reactive astrocytes. It tends to have less inflammation, and also some role in the bioenergetics of the neurons. So all these factors worked through this following mechanisms. There was an increase in the activity of neurotransmitters, the excitatory ones, for example, cholinergic, serotoninergic, and some others. And as opposed to progesterone, there is a lesson of like gamma-aminobutyric acid. It also has been shown that the neural circuits are better maintenance, and also a prevention of ischemia via the production of nitric oxide that tends to increase cerebral blood flow. Oxidative damage prevention, as I told you, acting as an antioxidant, and some changes in lipids. The synthesis of neurotropic factors, like which are called neurotropins, that maintain healthy neurons, the protection against the toxicity of beta amyloid, some action in the axonal regeneration via the oligodendrocytes in the peripheral nervous system or in the Schwann cells in the central nervous system, and also tends to increase and make better connections, synaptogenesis, between dendrites and axons. And all these effects were well documented. So what happened, what is the dichotomy between those potential beneficial effects and the results of the WHI and ancillary studies? Well, there are three major points to consider. One of them is, was called by Sherwin and Pauline Mackey, the timing or critical window, which is very similar to what we see in the cardiovascular area, which states that if we gave the estrogen therapy early in the life of the patient, we will do better. That is, if we make the treatment in the perimenopausal period and not in older women, we can have a better results. How wide is this critical window? We do not know, but it seems to be a possible explanation. The other one is which is called the healthy cell bias, in which states that the effect of estrogen depends on the health of the cell. If the neuron or the cells are healthy, the organelles, the mitochondria, the nucleus, the membranes, etc., are healthy, their results will be much better. So these two are very important. And finally, let's not forget that the type and dose of HRT used might have importance. We do not know at the present which is better, if transdermal or another kind of administration, in which is the ideal product. It seems to be that natural estradiol is the best. But if we have women with the uterus, we must consider using a progestin, and that is not well proven which one is the best. It is probable that progesterone, which is the natural steroid, or dydrogesterone, which is very similar in the pharmacological and pharmacodynamic point of view than progesterone. There are a lot of studies addressing the critical window hypothesis, like the Kaiser permanent study, the Remember study, research into memory, brain function, and estrogen replacement, the Mirage, multi-institute research in Alzheimer's epidemiology studies, the famous WIMS, Women's Health Initiative memory study, and then there's a sub-study which adds an Y, WIMC, which means that the patients are stratified according to their age groups. And finally, the study of women across the nation, the SWAN study. So, answering the question, which is the topic of this webinar, which patient profile benefits the most in the case of this therapy functions in this regard, we can say that it would be the perimenopausal women, or that women with premature ovarian failure, which has brain fog, who is less than 60 years old, who is young with healthy neurons, who has young and healthy neurons, no degenerative diseases so far, and preferably which uses estradiol and progestin, similar to progesterone or dydrogesterone. Now, the well-proven effect of long-term HRT or MHT is osteoporosis, the prevention of osteoporosis and reduction of fracture risk. Here we have the stages of reproductive aging of women plus 10, in which I want to show you this window in which 1 to 3 years before the last menstrual period and lasting for about 5 or 6 years, there is a rapid bone loss epoch, in which the women loses around 2% of the bone mineral density per year, which makes a total of 10 to 12% in this window. After this, the rate lowers to about 0.5%. So by the time that the patient gets to 80 years old, she might have lost around 30% of her peak bone mass, which is a lot. There are a lot of studies in the field of prevention, the effectiveness of estrogen and progestin therapy in bone, like for example, the PEPI study, the postmenopausal estrogen and progestin intervention trial, which show that all active regimens, estrogen alone, conjugated equine estrogens and medroxyprogesterone, or estrogen alone, did much better than placebo group, and provided an increases of about 2 and 5% in bone mineral density at the hip and spine respectively. And then the famous WHI, which was not the primary target, this thing, but there were also studied. And the same, the combine the groups which use hormone therapy, estrogen alone or combined with medroxyprogesterone, had an overall 33% reduction in hip fracture and 36% on vertebral fractures. So it's a very effective anti-resorptive, the hormone therapy. In this graph, it is taken from the 13-year follow-up study from the hormone trials of WHI. We can see two parts. Here is the estrogen alone part, and here is the combined estrogen plus methoxyprogesterone acetate. And we can see this zero line, and above we can see some yellow bars, and below some blue bars, which mean which is up means more risk. For example, in the estrogen alone trial, there's an increase in the vein thrombosis or pulmonary thrombi, and the same what happens in the combined group. But there is a tendency to protection in some things like stroke, for example, or in the estrogen alone arm, breast cancer protection. And here is what is relevant for us today, is all fractures were reduced in an important way. The same happened with the combined estrogen and progestin arm of this study. So there are not enough data to use estrogen and progestin in the prevention of fractures and in the prevention of osteoporosis. Here are depicted the efficacy of various commonly used drugs for osteoporosis or osteopenia, like, for example, abaloparatide in non-ventral fractures. The persons who use it had a relative risk compared to placebo, 0.5%, denosumab, 0.8%, and estrogen and progestin, 0.7%. In vertebral fractures, we have similar numbers. Abaloparatide 0.15, denosumab 0.32, and estrogen with progestin 0.65. So there is a good numbers for protection against this problem. Which is interesting is that the patient that is treated by vasomotor symptoms, for example, with estrogen alone or with estrogen and progestin, does not need another antiresorptive at the same time. But in the moment that we finish the hormonal therapy, which we suspend, it is important to switch to another one, for example, to alendronate, because otherwise that rapid bone loss that I showed you before will resume, and we will have a net decrease in bone mineral density.
So, answering the question of the topic of the webinar, which patient profile benefits the most, we can say that the patient which will benefit would be those perimenopausal women which have made a good big bone mass, or with premature ovarian failure, who has no other risk factors for osteoporosis, who is non-smoker, who is less than 65 years old, and who has normal bone mineral density, because we are talking about prevention, not treatment, or osteopenia. In the case that the patient has osteoporosis, there are no indication for use of estrogen. There are another osteoanabolic or another antiresorptive drugs. And ideally that she is physically active, the patient. So those two topics I think that were interesting in the long term, taking into account that the patient will use hormone therapy for more than 1 year, and we can expect that in the near future those effects of the central nervous system will be more clearly defined, and perhaps we can have a good thing for preventing degenerative diseases of the central nervous system, and we will reduce and define how big is this
how wide is this window of opportunity that we have as well as in the cardiovascular system. I thank you very much for your attention. I will be ready for questions when it comes to that point. Thank you very much.
Thank you very much, Dr. Vasquez, for this extraordinary interesting, I would say, presentation. We have more to discuss on the use of oral HRT, and for this purpose, I would like to invite a second speaker today, who is Associate Professor Paulina Villaseca, gynecologist working on the field of gynecological endocrinology in the Department of Endocrinology at the Pontifical Catholic University of Chile, and also a researcher in the Centro de Excelencia en Biomedicina de Magallanes, also heavily involved in the academics and the research and the science around menopause. Dr. Villaseca, I would like to invite you to start with your presentation. We're looking forward to hearing from you.
Thank you, Elena. Good day to everybody in EMAS today. Professor Vasquez, your nice talk. Dr. Armeni leading this presentation. And I thank the opportunity to share this topic with you. And now we will address the potential effects of menopause hormone therapy on symptoms. I'm sharing my desk now on symptoms, climacteric symptoms and sexual function. So here we go. This is my disclosures. And amongst the main benefits of menopause hormone therapy is the management of symptomatology. Vasomotor symptoms, vulvovaginal atrophy symptoms, mood and well-being, and as you already saw, the prevention of bone loss and osteoporotic fractures. So, in this aspect, there is consensual indication for estrogen or estrogen-progesterone therapy in the menopause when a woman has this symptomatology. So now, is there a long-term effect of menopause hormone therapy on symptoms or on sexual function? On the climacteric symptoms, a long-term effect is not expected really. The vasomotor, flashing, diaphoresis are mainly prevalent in the early years of the menopause, and vaginal dryness are also a well-established symptom of perimenopausal and postmenopausal women that prolongs in the lifetime. So here, hot flashes, we see that they have an average of duration of 6 to 10 years, and vaginal dryness persists lifelong if untreated. Then, even more, there are some women who have persistence of these vasomotor symptoms for years or decades. Most women stop flashing in their life when they have important flashing in the beginning of menopause. But still, in the decade of the 60s and in the decade of the 70s, there is an important group of women that still have moderate to severe symptomatology. More than 10% in the 60s and nearly 10% in the 70s. Regarding mood disorders and perimenopausal depression in particular, these are multifactorial, there are multifactorial origins, and notably the prevalence of symptomatology, significant symptomatology in the menopause, and have these symptoms untreated, is a main association with depression, as well as all the other factors that we see in our patients in this biographical part of life. We gynecologists have certainty of the anatomical changes that we can see in the vagina that constitute the genitourinary syndrome of menopause, which affects sexual function. We can see the paleness of the tissues, the loss of folds and elasticity, the marked thinning of the skin, reduced blood supply that avoids the excitatory physiological response of vasodilation, and the reduced lubrication that provokes pain. There's this Latin American study by the Red Link group that has done lots of research in Latin American issues related to menopause. And this study in middle-aged women could see in more than 7,000 women that there was a high prevalence of sexual dysfunction. More than 50% of women can be diagnosed with sexual dysfunction with a female sexual function index. In some countries, it was even up to 80%. And the main risk factor for sexual dysfunction was vaginal dryness, with a clearly significant odds ratio. So, since being the absence of problems associated with sexual complaints, a Cochrane study assessed the effect of hormone therapy on perimenopausal and postmenopausal women, particularly in sexual function. And we could see that there is a small to moderate improvement in menopausal symptomatic women treated with estrogens alone than placebo, or with estrogens and progestogens compared to placebo, when the women are symptomatic, and mostly when they are in their early menopausal years, postmenopausal years up to 5 years. And this is not so when the women were not selected by symptomatology. Then there is no effect of hormone therapy to this regard. There's also a study in Melbourne with a group of Susan Davis on hypoactive sex desire dysfunction in older women, women from 65 to 79 years old, and we see an important prevalence of sexual problems, low sexual desire, 88%, and distress, sexually related personal distress, 15%, highly significant in these aged women. And it's important to note that vaginal dryness during intercourse was one of the main issues that affected women's sexual function and distress regarding it. It's nice to say that being pregnant is more distressing than being unpregnant, because of course there's a function that needs to be solved. Now, what happens then when there's discontinuation of menopause hormone therapy? After the WHI was stopped abruptly in 2002, there was a massive discontinuation of therapy worldwide. And this was due to a massive press release worldwide as well, prior to scientific analysis. There was panic in users and even in the doctors treating these patients. So what was the consequence of that? 1 year later, Deborah Grady, the group, she was one of the main researchers of the WHI study, they published a paper on predictors of difficulty when discontinuing postmenopausal hormone therapy. These were women from a closed health plan, 50 to 69-year-old women that were regular users of hormone therapy for at least 1 year before July 2002, when the WHI study was published, and who had attempted to stop hormone therapy. And what happened? More than half of them tried to stop hormone therapy, those who were on hormone therapy, of course, and of these, 74% maintained discontinuation, though 19%, one-fifth of them, evolved with significant symptoms. And even more, 5% reported initiating alternative therapies for the relief of symptoms. Probably at least one-fifth of them needed something to relieve their symptoms. One-fourth of these women resumed taking hormone therapy, and the main predictor was development of troublesome withdrawal symptoms, with a relative risk of 8.8, very high relative risk, having troublesome withdrawal symptoms of all kinds. Also, systemic symptoms as hot flashes, diaphoresis, insomnia, fatigue, depression, and also vaginal dryness. As you saw with Dr. Vasquez, Professor Vasquez, estrogens have a main role in prevention of fractures and osteoporosis, and continuation of hormone therapy here. We can see that as hormone therapy use rate decreases, the hip fracture risk significantly increased 1, 2, 3 years after discontinuation. So there was a high risk of 1.55, a 55% increase of risk, fracture risk. And then there were people that needed to be moved to bisphosphonates to treat their osteoporosis. So there is an impact on discontinuation of hormone therapy. Then we need to learn that to treat the main benefits of menopause hormone therapy, which are management of vasomotor symptoms, management of symptoms of vulvovaginal atrophy, improved mood and well-being, as well as preventing osteoporosis fractures. We learn in the women that need this for prolonged time to treat them without harming the cardiovascular system and minimizing breast and endometrial risk. There are tools that help us to calculate the risk factor for these main associations, negative associations that could occur with menopause therapy, as you saw in the graphs that Dr. Vasquez showed. One of them is this National Cancer Institute breast cancer risk assessment tool that you downloaded from the web. You can even do it together with the patient. And this shows the you can calculate the personal 5-year risk of developing breast cancer in the patient and compare it with the average population risk, as well as the lifetime risk of developing breast cancer of the patient, and compare it with the average risk. And this is a helpful tool to decide if we can initiate or maintain hormone treatment. The questions that this includes are women's age of the first menstrual period, the age of the first live birth at childhood. So the main demographical and are treated here to know, and of course breast density, other breast factors, as having had biopsies, are treated here in this assessment tool. These tools do not take into consideration the breast density, and we know that breast density, as we see here, a very dense breast as compared to this very non-dense breast. This is a strong independent predictor of breast cancer. So there are studies ongoing to describe objectively the density of the breasts, so we can incorporate it in the breast cancer assessment tools. Nevertheless, we can also look at the mammogram. We don't only read the inform of a mammogram, we have to look at the image to see the architecture of the breast, because it's different if we find this very dense breast than this very low density breast in regards of breast cancer risk. There's also cardiovascular risk assessment tools for the menopause hormone therapy decision. This is a cardiovascular risk calculator that you can also have it in your office and do it together with the patient. This is supported by the American College of Cardiology and the American Heart Association, and considers different risk factors of cardiovascular health. There are other cardiovascular risk calculators, and the important issue is that you would use the one that is validated in your country. Of course, we're talking of all validated calculators. And this permits to decide the 10-year risk of the person you're treating in front of you, of cardiovascular risk. If we calculate that this person has low risk, less than 5% of having a cardiovascular event in the next 10 years, and the person is less than 5 years menopausal or 6 to 10 years menopausal, she can begin and can maintain menopause hormone therapy. If the risk is moderate, from 5 to 10%, then hormone therapy can be used, but we should choose transdermal. And I think that's one of the topics that we will talk later, and Elena is wishing to talk about. And when the woman has high risk, over 10% of the chance to having a cardiovascular event, then no hormone therapy can be used at all. And you have to choose, if the person is too symptomatic, you have to choose non-hormonal treatments for her. So, on long-term effects of menopause hormone therapy, we can conclude that there's no long-term effect achieved with menopause hormone therapy on postmenopausal symptomatology, and that there's only small to moderate effect achieved with menopause hormone therapy on sexual function in symptomatic women, but that is lost when you discontinue the treatment. So the issue is long-term effects of menopause hormone therapy versus long-term or prolonged therapies. And women that need it, we should think about prolonged menopause hormone therapy. On general symptomatology, we should consider this if they're persistently symptomatic. And on menopause, on sexual function, it is a more complicated issue, since this requires specific psychosocial management, partnered management, and of course maintaining the gynecological trophism, as well as other possible medical approaches, as eventually using androgens or others. On the duration of treatment then, the decision on maintaining a treatment is individualized, and this depends on the reasons for the indication, the balance of intensity and invasiveness of symptoms versus individual risks related to treatment. The treatment then can be maintained while the benefits are required, always reassessing the risk factors that appear over the year in our control of the patient on the climacteric syndrome. So this is what I wanted to share, and we're open to the discussion.
Professor Villasencas, thank you very much for this very interesting presentation. I would like to invite Professor Vasquez to join us again on the panel so that we can start going ahead, trying to answer all of your very interesting questions. So the first question, Professor Vasquez, are you with us?
Yes, I am.
Excellent. So the first question I would like to start with is something very relevant to Paulina's presentation. If you could remind us again, the question was if HRT oral or transdermal can be given to patients with MI or non-cardiovascular disease, and what to do in fatty liver. I briefly noted a slide in Paulina's presentation related with this topic, so I would like to address this question to you.
Okay, well, if there has been a myocardial infarction or vascular brain accident, then that's total contraindication for use of hormones by any by any way of giving it, which is different on the woman that has some cardiovascular factor risks, but not had already a cardiovascular event. If somebody has cardiovascular factor risks and give a high cardiovascular risk for an event, then we can use transdermal. And that's the reason is that the transdermal administration, it skips the liver. So it goes directly into systemic circulation and the synthetic proteins that can add to the risk. Now, on fatty liver, well, there's different grades of fatty liver. When the fatty liver is already showing like hepatic insufficiency, then we should think about it. Although chronic hepatic insufficiency, when it's not severe, it does not contraindicate the use of hormone therapy when needed. And in those cases, of course, we choose the transdermal administration way to skip the pharmacological effect of the absorption, the liver, when we take an oral treatment.
Thank you very much. And a quick comment on a related question. One of participants was asking, in the UK we use Q-RISK-2 score. How does this compare with SCORE that is used in Europe or the American Heart Association risk assessment? Thank you.
Well, as I mentioned, the two risk calculators that we should use are the ones that are validated in each country. In my country, in Chile, we have validated for the country the American Heart Association tool. So that's the one we use here. But the UK has their own calculator. That's the one you should use.
Thank you.
And yeah, if you calculate a high risk over 10% of having a cardiovascular event, then you should not indicate maintain therapy.
Thank you very much for this. I will move on to a question related with osteoporosis for Professor Vasquez. In under 65 with osteoporosis, what dose of HRT can be advised? Bisphosphonates can be used after 60 as it requires drug holiday after 5 years. We're looking forward to hearing your opinion on this.
Yes, osteoporosis is one thing. Osteoporosis prevention and fracture risk prevention is one topic that it's dose related of estrogen. For example, we know that we have normal doses, which is about 2 milligrams of estradiol and 0.6 conjugated equine estrogen. But we also have lower doses, 1 milligram of estradiol, 0.3 of conjugated equine estrogen. So the standard dose of about 2 milligrams of estradiol will be enough to maintain the bone density, and I will use it in a woman with the risk of osteoporosis and with osteopenia until she's 60, and if she has also vasomotor symptoms. I will not use it for more than 60, when she is older than 65 years old, then I will switch to bisphosphonates, which we can use for 5 or 6 years. And that famous holiday year that many people advise, it's open to discussion between the experts. Many of them recommend it, and some of them say that it is not good because bone loss will turn to a rapid bone loss. And personally, I use, when I have used the bisphosphonates by about 5 years, because I have had good results. But there's a lot of controversy about that topic.
Thank you very much. I would like to continue with Jose and another question related with bones. If a premenopausal woman has osteopenia, would you advise starting HRT and taking indefinitely?
Well, if she has a risk, we can calculate the risk of fracture using the FRAX. Yes, we can use hormone therapy, but not indefinitely that when she is 65 or it was more than when she's older, it is not the best treatment for that, and then I will use another antiresorptive. But if she is perimenopausal, yes, it is a good indication.
Thank you very much. Now a question possibly for both of you, but I will just turn to Paulina because we had already 2 questions for you, Jose. I don't want to just keep you going without any break. So feel free to join after Paulina. The question is, how and when do we move from contraception over to HRT?
Well, when we're certain that the woman doesn't need contraception anymore. And that's a very difficult question to answer. The consensus show that if you measure FSH during hormonal contraceptive treatment, and it is superior to 25 international units, and that is repeated so 3 months later, then she could suspend menopause contraceptives and change directly to a hormone therapy system. But then we know that the menopausal transition sometimes takes many years, and it is a problem to reinitiate oral contraceptives in somebody that is 48 years old or 50 years old because of the thrombosis risks that are associated mainly with the initiation. So my personal approach is to wait at least a year with high FSH to decide the moving to menopause hormone therapy. And you can go directly to stop one, and instead of beginning the next pack of oral contraceptives, then begin with the first pack of the hormone therapy that we decide to use in this lady. And it could be combined continuous as to not have any more bleeding, or do a sequential independently, mostly on what's the preference of the patient.
Thank you very much, Jose. Anything different in your personal practice?
I completely agree. FSH is used a long time ago in a patient which is using contraceptives. We asked her to stop the contraceptive, wait until day 2 or 3 of her menstrual period, measure FSH, and if it is higher than 25 units, it is the indicative that the ovary is not working anymore. The difference is because HRT uses higher doses than menopausal hormone therapy, and another kind of estrogen. For example, many contraceptives uses ethinylestradiol, which is very potent estrogen for the purpose of treating vasomotor symptoms and symptoms of the menopause. So it is important to make the transition, but also to be sure that the patient will not get pregnant, because the doses used in HRT, it is not enough to prevent ovulation in some cases. You wrote recently an article talking about the levels of anti-Mullerian hormone for predicting in which time will the menopause the ovarian will fail. But I think that you found mostly that it is correlated with the severity of vasomotor symptoms more than to predict when the menopause will be taking place.
Indeed, yes. So
maybe add that after using contraception, we can of course wait for a period without any treatment at all and see if the patient gets the symptomatology that indicates menopause hormone therapy, or if we see any other reason for the indication of it.
That's a very sensible approach. I would definitely support this plan, if there is no strong factor of why we should go into HRT straight away. I'm moving on because we have a very actively participating audience, which is very good. Back to, now that we are with Paulina, there is a question related with vaginal dryness. So the question is, if we were to add testosterone for vaginal dryness, when in particular would you add in testosterone for vaginal dryness?
Well, testosterone has an important role on desire. But if we do not have the vaginal dryness treated, the atrophy treated, if we administrate testosterone or another systemic androgen, there could not be enough response for it. So it is shown that adding systemic testosterone to estrogen therapy can add on trophism and on desire, when it is a factor influencing libido and sexual response, which is not so correlated. But there's also androgen local treatments. We don't have it at home, which is progesterone or DHEA, dehydroepiandrosterone, for local treatment, as well as local estrogens that are efficient in keeping the trophism. In fact, when I was a very young doctor, we had a composite of a cream that had estrogens, conjugated estrogen cream with progesterone, and that was superb. And unfortunately, it was lost many years ago. It's not anymore, at least not that I know in the United States either, but maybe they have. So yeah, testosterone, local androgens can be helpful for trophism. And androgens, systemic androgens, can be helpful for libido. But it is also helpful when they are both synchronically used.
Thank you very much. Now, I have two more very interesting questions I want to address to both of you. The first is related with migraines. If estrogen is contraindicated due to migraines, etc., but the patient still wants benefit of prevention from estrogen, what would you suggest? Let's start with the ladies. Paulina, what do you think?
Well, if migraines have neurological compromise with each episode, then that's still a contraindication, and the person shouldn't treatment, and that's because this kind of migraines are mostly associated to accidents, vascular accidents, stroke. There are migraines that appear with menopause, or people who have migraines in their lifetime and increase importantly with menopause. And then the absence of estrogens has a role in the appearance or increasement of the migraines. And then, in agreement with the neurologist and with the patient, you can try a transdermal therapy, low-dose transdermal therapy, and see if the vasomotor stability that gives to all arteries, including the ones in the brain, can help to treat the migraines that sometimes are untreatable even with neurological treatments. So it can be an indication, even more, as an atypical symptom of has to be treated very carefully because of the stroke risk, which is, I think, the worst risk that one can have, even worse than breast cancer. No? It appears and then it's done. There's no treatment, it's done. It left the sequela if you do not treat it immediately.
Thank you, Paulina. Jose, do you want to add anything on the same question?
I completely agree. If a patient has classic migraine, I will not recommend. I will discuss with the patient on other options, and surely I will look for the neurologist opinion, because, and I can tell you, most of them will say, no, do not give estrogen. I know that in some countries they give transdermal estrogen in those cases, but personally I will not do that.
Thank you very much. I continue with bones because we have a very strong interest from the side of Q&A. Congratulations in particular from Mexico to Mexico for the excellent presentation. And Rafael Bedoya Torres from Mexico wants to ask the following question. There are articles for and against suspending MHT, menopause hormone therapy, regarding the favorable effect on bone density and fractures. Some say that it is lost and others that it is maintained for some time. What is your opinion?
Yes, my friend Rafael Bedoya is asking me a very good question. I will say that if we stop hormone therapy for bone protection, almost surely the rapid bone loss will continue, and 1 or 2 years after suspending, the bone mineral density will be very low. So I prefer to change to another anti-resorptive, which in the most cases is alendronate or ivandronate, any of those, because if I leave her without any treatment, it surely will again lose bone mineral density. And I think that yes, there are articles that say the contrary, but the consensus is that you should switch to another anti-resorptive drug.
Thank you very much. Continuing with the bones, because the audience seems to love the topic. There is one question asking, at the menopause transition, what would be the suggested management for in a lady with osteopenia and fracture risk? And what would you do on somebody who is going through menopause with regards to bone management? Just a summary.
Yes, in a patient with premature ovarian failure, to begin as early as possible the treatment, if she has no contraindication, of course, for that purpose, and to give a standard dose, 2 milligrams, or even 1 milligram if it's enough for controlling other symptoms. And in the perimenopausal women, I will add to the estrogen and progestin if she has uterus, calcium, and maybe I will measure 25-hydroxy vitamin D to see if she is deficient in vitamin D, and then supplement it for at least when she's 65.
Thank you very much. One last bone question, and then we continue a little bit more with Paulina. I told you the audience is great today. So the question is if you think the Tibolone has the same bone protective effect as estrogen progesterone hormone replacement therapy.
Yes, well, Tibolone is progestin. It's classified as a progestin, which are very special properties. I think it's not available in many countries. We have in Mexico Tibolone, and it has a bone sparing effect that is almost comparable to estrogen. So it's a good option also for that purpose.
Thank you very much. Paulina, back to you. The question is if somebody could use THR in women with endometriosis, what would be your impression?
Yes, you can use menopause hormone therapy in women with endometriosis, making sure that you use potent progestogen that does not permit the endometriosis to again proliferate. Even there's one indication of using progestogen in women operated on and without uterus hysterectomized because of endometriosis or any other reason, and they still are thought to need the progestogen even without a uterus, because there might be the chance that there are endometrial cells somewhere in the body, and then this can appear and produce an endometrioid carcinoma when estrogens alone are used. Tibolone is also a good possibility of treatment in women with endometriosis.
Thank you very much. And then if you want, both of you actually, to answer the question, why do we actually favor in particular oral rather than transdermal delivery?
No, we do not favor one over another. It is a matter of many factors, the pharmacokinetic properties of one another, depending on the patient. The preference of the patient is also important because, for example, if he uses transdermal, let's say in the form of creams, it is an easier way to, let's say, to dosificate herself. For example, if I told her use one quantity and she feels that it is too much, she can use half that amount, so she can in some way dosificate herself in a less dose, which is not possible with the oral or another forms of treatment. It is a question of pros and cons between one and another. It's not that we are favoring one particular form of a route of administration.
Thank you very much, Jose. Paulina, do you want to add anything?
Yes. Here at home, transdermal therapy is much more expensive than oral. I guess in Latin America it is so. And then we sometimes favor oral treatment because it's just possible to buy and maintain, like pay for it every month. And there are specific indications of transdermal estrogens, and then that is what should be used and not oral, as in, for example, hypertriglyceridemia, dermal that are absolutely transdermal.
And maybe I wish to answer, I mean, there's in the chat, there are two issues, if I can shortly. One is that there's no accuracy in measuring FSH in women that are taking HRT or oral contraceptives or hormonal contraceptives of any kind. That's true, but since there is this negative feedback, even if we, the measurement we do will be lower than what it really is. So if we measure 25 and it is negatively feedbacked, then we assume that this patient has a higher FSH. So it gives an idea. It is not accurate, but it allows to give an idea and decide if we will discontinue the contraceptive or not. Now, discontinuing contraceptives to measure FSH, I think it's tricky because the woman can become pregnant on one side, and then it's difficult to begin again an oral contraception when she's over 45. And the other question is on migraines, and in the UK, migraines with aura, and also people have had a stroke. The British Menopause Society accepts using transdermal estrogens in very low doses. Yes, it can be. But it is a pathology that can have so big sequela that I think that person is preferable, has the indication to see any other treatment that doesn't offer not even the very little risk of another stroke or a stroke before the hard decision using hormone therapy, transdermal, low dose.
Lovely. Paulina, if you don't mind, we have one last runner-up question on Tibolon, which came up literally 2 minutes ago. I understand the audience find it very interesting. I also find it very interesting, so I would like to invite both of you to try and address the question if you would use Tibolon in women over 60 years of age, specifically if they have been on it. Do we need to change it when they turn 60, given the risk for stroke? What would you recommend?
I definitely not use it in women older than 60 years old. It has the same risks. It is a molecule that has androgenic, progestogenic, and estrogenic actions, but definitively, I will not use it in women older than 60 years old, irrespective of the cause. I will look for another options for that patient.
Thank you. Paulina, what about you?
I agree with that. I prefer to move people from Tivolone to hormone estrogen treatment, or transdermal, or because the risk of stroke is like an increase of 215%. I mean, the estrogen-only WHI study was stopped because of a 50% increase of stroke. And then it was realized that it was people specifically over 60 as well, and because this was an oral treatment, and with Tivolone it is much more. Now, if the person is, as I see in the chat, very fit, has no risk factors at all, no family history, everything is perfect, she exercises, never smoked, and has the perfect conditions, maybe. But still, we always prefer to use that wouldn't add not one bit of a risk of such a severe problem as a stroke is.
Thank you very much. Thanks to both of you. Thank you, Jose. Thank you, for Paulina. Thank to all the translators for this excellent webinar. We are 7 minutes past our time, so I would like to close the session for today. Thanks to EMAS and to Abbott for organizing this very beautiful discussion with those amazing professors.